Hi, my name is Atif Darush, professor and consultant of obstetrics and gynecology. Actually, I noticed that many doctors who already have hysteroscopy machine in their clinics or in their hospitals are overusing this tool for diagnosing many cases without evident indication of the role of hysteroscopy in such cases. Here is an example of the overuse of hysteroscopy, which is in the cases of adenomyosis. We know that adenomyosis is defined simply as invasion of the endometrial glands and stroma into the myometrium and presenting with pain, bleeding, and dysmenorrhea, and sometimes infertility with decreased pregnancy and life birth rates and increased miscarriage rate. It can be classified into localized adenomyosis, which is adenomyotic nodule, or diffuse, which includes most of the myometrium. And this diffuse can be superficial nearby the endometrial cavity or deep, which is invading the whole myometrium of the uterus. But actually, the state of the art comes from the radiology department, who have the advantage of describing the junctional zone, which is the inner myometrial layer immediately underlying the endometrium and is composed of higher cellular density layer. And they noticed this junction zone by MRI as low signal intensity zone, and they started to evaluate this junctional zone in myometrial diseases, particularly adenomyosis, and they noticed altered junctional zone. And this was the key of the start, the state of the art of success in diagnosis of adenomyosis. Of course, by transvaginal ultrasonography and 3D ultrasonography, we followed the MRI for diagnosing adenomyosis, and the junctional zone is diagnosed as hypoechogenic zone around the endometrium. And later on, the scientists all over the world started to highlight the role of transvaginal ultrasonography in the diagnosis of adenomyosis until the MUSA features were described. And these morphological uterus sonographic assessment features are revised and recently published. When you see the uterus in globular in shape, this goes with adenomyosis with asymmetrical thickening. This also goes with adenomyosis, echogenic subendometrial lines and buds, some hypoechogenic cysts and hyperechogenic islands, uh, trans, some myometrial increased vascularity, irregular junction zone or interrupted junction zone, or fan-shaped shadowing. And these are seen here in this figure on the right side. You can see interrupted junction zone, irregular junction zone. You can see asymmetric myometrial thickening. Here is thin and here it thick, as the posterior wall is thick. You can see globular uterus, echogenic subendometrial lines and buds, translesional vascularity, fan-shaped shadowing posteriorly, hyperechogenic islands or hypoechogenic cysts. And actually, these MUSA criteria were classified into direct and indirect. Direct, where when you see hypoechogenic cysts or hyperechogenic islands or echogenic subendomyometrial lines and buds. The indirect are the REST 6 criteria or the 9 criteria of MUSA consensus. Another description of the abnormal myometrium in cases of adenomyosis is to comment on the thickness of the junctional zone. If it is 8 millimeter or less, this is normal junction zone, but if it is more than 10 to 12 millimeters, this goes with adenomyosis. So the comment on thickness of the junction zone is important. Also, some studies mentioned that junction zone may be linear, may be serrated, And linear means that there is no invasion, the myometrial invasion is less than 3 millimeter in contact with the basal endometrium, and serrated is more than 3 millimeter, but still in contact with the basal layer. And if adenomyosis is away from the endometrium, it's called intrinsic adenomyosis. Now we have to discuss the topic of this short lecture. Can we use hysteroscopy for diagnosing and treating adenomyosis? This is a question. The diagnosis has advantage of direct visualization of the endometrial cavity and to take histopathology from the myometrium and endometrium under direct control, and we have studies on myometrial biopsies by hysteroscopy. But hysteroscopy is not the first line diagnostic approach of adenomyosis. Why? Simply because adenomyosis is a myometrial lesion, not endometrial lesion. And regarding the treatment, therapeutic role of hysteroscopy, can we use it to treat adenomyosis? It can be used for treating focal adenomyosis or superficial diffuse adenomyosis. So either focal or superficial diffuse, but deep adenomyosis is not suitable for hysteroscopy. So hysteroscopy is not the first line of treatment approach of adenomyosis. Uh, as I told you, it's just for superficial lesions and for hemorrhagic cysts, superficial hemorrhagic cysts, and we can use TCR-EM, which is endomyometrial resection. So it is not ideal. It is not the first line diagnostic approach in adenomyosis and not the first line treating approach for adenomyosis. So if you have a hysteroscopy telescope or machine, don't rush to do it in all cases of adenomyosis. Here are some publications describing the hysteroscopic appearance of the endometrial cavity in cases of adenomyosis. You can see irregular endometrium with tiny opening seen on the endometrial surface. You can see pronounced hypervascularization, strawberry appearance, fibrous cystic appearance of the intrauterine lesion, hemorrhagic cystic lesions as seen in these pictures. And here is an example of how to see the adenomyosis by hysteroscopy. You can see the endometrial cavity shows that there is some abnormal uh, brownish lesion in the endometrium. These are signifying that the myometrium contains adenomyosis, and these are like chocolate material inside the blood vessels, in addition to increased vascularity, of course. And this comes with suspicion of diagnosis of adenomyosis, but not 100% sure of diagnosing such a case. Here is the operative or therapeutic excision of a nodule, which is extending inside the endometrial cavity, and in such a case, this is a focal adenomyosis and can be seen by transvaginal ultrasonography encroaching on the cavity. Here, when you cut the lesion, you will see the brownish discharge, which is characteristic of retained endometrial glands and stroma inside the lesion. So it is a focal lesion of adenomyosis rather than being a focal fibroid. And of course, you can by ultrasound differentiate between fibroid and adenomyosis. These brownish discharges of chocolate material are characteristic and pathognomonic of adenomyosis inside the myometrium, and the focal adenomyosis is going inside the endometrial cavity, and this is an important indication of hysteroscopy, is to excise focal lesions inside the endometrial cavity, and not necessarily to be a polyp or not necessarily to be fibroid because of the appearance of this chocolate material. Here in this picture, you can see a trial to excise endometrial small subendometrial lesion using micro scissors to cut this lesion and to see the what's is inside, and you can see again brownish discharge suggestive of adenomyosis. In some studies, they used the 5 French bipolar electrode to open focal lesions or focal and adenomyotic cysts from the hysteroscopy side. These procedures are done whenever ultrasound signifying that the lesion is near to the endometrial cavity. Otherwise, don't rush with the hysteroscopy to do invasion of the myometrium without clear demonstration of the site of adenomyosis. Another indication of therapeutic hysteroscopy in adenomyosis is to treat superficial adenomyosis, and this can be done for patients with linear junctional zone and serrated junctional zone as described by many authors, but patients with intrinsic adenomyosis, which is away from the endometrial line, don't go with resectoscopy because you are, in such a case, you are excising the endometrium, but the lesion inside the endometrium and away from the loop. So the patient will have the same complaint of pain and bleeding, and this is expected to be a failed TCREM. So don't do TCREM unless the lesion is superficial, less than 3 millimeter, serrated junctional zone, and this can you can achieve. Otherwise, re-intervention surgery is needed up to hysterectomy if failed hysteroscopic resection of the endomyometrium. So the disadvantages of hysteroscopic rule of adenomyosis in cases of diagnostic lesion cannot establish a definitive diagnosis of adenomyosis. The MUSA criteria and other sonographic criteria, including comment on the junctional zone thickening and serration of the junctional zone, are more advantageous and more accurate than hysteroscopy because the hysteroscopy is seeing just the endometrial cavity. Regarding operative hysteroscopy, its rule is for focal lesion and for superficial endomyometrial resection. So diagnostic hysteroscopy is not the first choice. It's done to exclude concomitant suspected lesions, and operative hysteroscopy is done for localized lesion or cystic lesion nearby the endometrial cavity as guided by transvaginal ultrasonography and 3D ultrasonography or MRI, and endomyometrial resection is done for superficial lesions with serrated junction zone only. Don't use it for intrinsic junctional zone or intrinsic adenomyosis. Thank you.